4, 3, 1. We are live now.
Good evening, everybody. Welcome to today's webinar brought to you by the Orthopedic Research and Education Foundation. Today
I seem to have lost the voice. I cannot.
Dr. UK Sadhoo from Delhi, so I don't need to do a lot of introduction, but suffice who's multi-talented in different fields is like a hobby to him. So with trochanteric fractures, the current treatment, and so without much ado, I think we will hand it over to trochanteric fractures, the current treatment and options. Over to you, Dr. Sadhoo.
Thank you, Dr. Mukhopadhaya. It's a pleasure to be here, and my thanks to the OREF Foundation and the team. Good evening. The subtrochanteric fracture, the topic itself is well chosen. It presents several challenges, many at many stages, including the assessment, the setting up of the table, the options of fixation, and the options of reduction. At every step, you face a challenge. We'll try and look at all of them and see the possible solutions to each. So, the peculiarity of the subtrochanteric fracture is that there are tremendous deforming forces. And as you can see, the abductors, they pull the proximal fragment into abduction, whereas the iliopsoas pulls it in flexion. So the adductors pull the distal fragment into adduction. So all these opposing forces produce what looks like a very grotesque deformity. And the trick lies in neutralizing in all these forces, holding them steady while you negotiate whatever fixation you are doing. Now, the difference between the various regions fractures, as you can see, is this is the neck trochanteric area, and 2 inches below the lesser trochanter area is where the subtrochanteric fracture is located. It is not necessary to have a single fracture line. You can have many fracture lines running up and down, but the epicenter is always at the area below the lesser trochanter within 2 inches. There are very many classifications, more than a dozen of this. Essentially, what you need to see is whether the fracture has a medial support or not, because that alters or at least influences the choice of implant and also gives you an idea about the violence. Now, talking of the force vector that these fractures are subjected to, essentially, there are 2 groups. One is in relatively young people, where they may have other injuries also, because this could be part of the polytrauma, or in somewhat elderly age group, 55 onwards, who may have this as an isolated fracture because of a fall. So the forces remain the same. And in an intact femur, as you can see, the line of weight bearing from the head to the center of the knee, it passes medial to the neck. What that does is it sets up an eccentric load which predisposes to a varus load on the femur. And you can imagine if there is a break anywhere here, the tendency of varus is accentuated. Therefore, we need very strong implants to resist the varus forces. It is pertinent to note that you need to have no reduction in varus because that is doomed to failure. Now, there are basically two kinds of implants that are utilized. One is something like a DHS, which is extramedullary, and the other is intramedullary nails. So plate from the outside or a nail from the inside. As you can see, the nails are, they have much less of a bending momentum because this lever arm is much less than this one, so that the forces across on the blade or the plate or the screw are a lot more in case of the implant on the surface compared to the intramedullary implants. In radiology, what you need to do is you have to have a pelvis anteroposterior X-ray to see both the hips, and you have to have a AP of the rest of the femur with the knee included. This is for two reasons, because A, to see the distal extension, and B, to see if there is any previous implant or surgery which may not have been noticed in the pure AP pelvis X-ray, because it could affect our type of fixation. Lateral view is not always easy, but it is of help to see what kind of bend in the distal anterolateral aspect of the femur is, and whether a nail could negotiate that or not. CT has a definite but somewhat limited role. It is not necessary to do CT in all the patients. If you suspect or see any kind of extension proximally, then it becomes necessary to define the components and see any occult extensions which may affect our choice of implant and the entry and even the reduction. I think in fixation options, we can straight away reject the conservative or so-called traction and the external fixation. These are almost a non-starter and really doomed to failure. So unless the patient is really in dire straits medically, these should not be considered at all. So we come back to the internal fixation. And as I said before, you can think of plates and intramedullary implants. Needless to say, intramedullary implants, for the reasons stated before, are much preferred options, though plates do have a place. There's a typical sort of fracture pattern, a transverse fracture below the lesser trochanter. If you see a clean transverse fracture, you have to think of bisphosphonates. This is a very typical, atypical form of fracture with the long-term bisphosphonates. So what kind of plates? You have conventional and you have so-called modern plates. So in the conventional, you have the option of dynamic hip screw and the 95-degree screw. The third is the blade plate, 95 degrees. The so-called modern version is the locking plate of the proximal femur. All the conventional plates have high failure, whether it is a dynamic hip screw or the condylar screw or the 130 degree or 95 degree blade plate. And if you see here this void or the deficit medially definitely predisposes to more varus, and the implant could fail laterally just opposite this. This is the reason nails are more preferred in this. They resist the bending stresses a lot more. If you have to use any kind of plate, ensure that the reduction is in valgus and definitely not in varus, as in these cases. I think this definitely would go on to delayed or non-union and the implant breakage. So a DHS is especially vulnerable because in the type of subtrochanteric fracture, which is reverse oblique, there is nothing to stop the shaft from moving medially. And this is one reason the DHS is not a preferred implant in subtrochanteric fractures. The other would be a cutout of the blade, the screw superolaterally in case there is varus, which keeps on increasing. And the only salvage thereafter would be a total hip replacement. As I said, the so-called modern plate, the proximal locking plate, is an implant that has its use. It can be used as a so-called minimal invasive technique, but the reduction has to be not in varus. I re-emphasize, you have to take extra care that there is no varus in this. So there is local irritation because the plate kind of tends to stand out, but the advantage is that you can use it as a minimal invasive option. This would be definitely one option if there is a some kind of comminution and you don't want to try and knit all the fragments together, small bits, to devascularize them. As with any plate, you have two kinds of stability. One is the absolute stability. Anytime you have an oblique fracture and you utilize that obliquity, any implant outside would be simply a buttress. So this becomes an absolute stability and there is very little callus to be seen. The relative stability, as you know, comes with screws that are put in the proximal and distal fragment and a bit away from the fracture side so that there is a relative movement there or at the comminution site to produce some callus, which is a very welcome sight. But whether it is absolute or the relative stability, the implant, the plate, or for that matter, the nail has to be adequate length also. Now, here is an example of so-called biological plating causing relative stability, and you have this reduction, again emphasizing not in varus. This fragment was not touched and it has joined as a live graft. This is an example of a long spiral oblique with a large, maybe possibly a butterfly fragment, in which I chose to take the option of absolute stability. Here you can see the anatomical reduction with the lag screws, and then the proximal plate has been used as a buttress plate, and you see the lack of very little callus, visible callus, yet the fracture has joined. So the plates need to be strong and long enough, and if there is a medial hinge integrity is not very visible, then it needs to be really supporting that till the biological technique works. And plates are best used with biological plating techniques so that the vascularity is preserved. Whether it is nail or a plate, failures are not uncommon. And all failures in varus. And the implant will break at the vulnerable point, plate where the fracture is. Here, the problem you see in this particular case is on the contralateral side, you have the fracture united because the fracture was not fixed in varus, whereas here the fracture was in varus, plus there is a medial void here. The circular wire shows that there may have been open reduction to fix this medial fragment. So a combination of problems has caused the breakage of nail, leading to subsequent delayed oblique non-union. And similar picture with a blade plate or a so-called DHS. Here the plate is beginning to bend. This happens to many Indian implants where the metal is maybe not quite up to the mark. So it starts bending first before it breaks. Coming to the preferred option of nails, there are some parameters. One, apart from the adequate length, is you have to have a reduction before you start reaming or nailing. Now, this point will be emphasized again. Now, this can be done with or without the fracture table. The length, as I've said, is long enough. The more comminution, the longer the implant. That is the hold, the effective hold in the proximal and the distal fragment has to be pretty long to avoid the stresses in the area of the comminution. If the lesser trochanter is intact, the standard locking, i.e. the oblique screw that goes near the lesser trochanter can be used. If not, then a reconstruction option, that is the proximal fixation going into the neck and the head. As I said, there are two ways you can put it on supine, or you can put it in the patient in somewhat lateral view. There are advantages and disadvantages of both. If you put the patient in supine, you have a better orientation, plus it is possible that the patient may have polytrauma in which supine may be necessary. The disadvantage would be to get to the lesser trochanter may not be as easy as in semi or complete lateral position. And the lateral position also reduces the so-called deforming forces, and you have much easier access to the lesser trochanter, that is the entry point. So both the positions have their own advantages and the disadvantages. Next, after the position comes the indirect reduction. This reduction of the fragments, as I said, you need to counter the many deforming forces, and you have to have a hold, especially on the proximal fragment. And there are very many ways, because not one of them is completely satisfactory. So a use of Sharan's pin, thereby manipulating, and once the fragment is in place, then passing the guide wire and holding these in position and reaming. Now, if you have to pass the Sharan's pin, you must not go through the mid canal. Otherwise, there will be problem in negotiating the guide wire, and definitely no reaming can be done. So it's a bit tricky, but you should try and get through the cortex without really violating much of the canal. EO distractor again comes in very handy to those who are used to this. It can be used in this particular fashion, or in this rather tricky Sharan's pin is applied just medial part of the neck, and this is transverse. So this becomes tricky because you need to have a good, this bone is very, very strong. So if you use the Shan spin, you have a very good hold of the proximal fragment, and the AO distractor has a graduated lengthening. So you can overcome almost any overlapping, but it's a tricky bit of instrument to negotiate. So the other tricks we have up our sleeves are the ball spikes, the hooks, and sometimes you have a proximal implant used as a reduction tool. So once you have patient on the table, a pressure on this proximal fragment to reduce the so-called flexion, neutralize that. You have the hook, which can be passed just over the lesser trochanter to manipulate the proximal fragment. Then, if you have taken the entry point, then a smaller size nail itself can be used as a manipulating tool, and a guide wire can be passed through this, while this tip is just about negotiated through from the proximal through the combination, if present, into the distal fragment, and then held as a reduction tool. Pass the guide wire, do the reaming, and then you can carry on with your reaming and placing the definitive nail. In any kind of obliquity, bone holding or the plate holding clamp comes in very handy through a relatively small incision. You put the one of the jaws across onto the distal fragment proximal end and reduce. It's a very strong instrument, and it will hold the reduction while the guide wire and the reamer and the nail is passed. The other option in this is a collinear clamp. Again, a very strong, sometimes excessively excessive forces can be applied through this, and in osteoporotic bone, it can actually cause some damage to the lateral cortex. So be careful with this collinear clamp. Cerclage wire is definitely an option. It is non-intrusive. It would not interfere in the negotiation of the wire at all. It is somewhat flimsy, but it can work. Anytime you are doing nail, the alignment is a crucial point, because the two fragments are independent. They can go into any sort of rotation deformity, and once the patient wakes up and you remove the drapes, you may find the foot in a very awkward external or internal rotation. So once again, it is not the job of a nail to reduce the fracture. You have to reduce and hold it to negotiate the reamer after passing the guide wire and the nail through into the distal part. A little bit more about the alignment. We have two guides, radiological. You have the lesser trochanter profile and you have the patella. Now, you see here it's a sort of normal profile in a normal bone, and if you have done good reduction, the patella would be in the center of the condyles, and the lesser trochanter will match the other lesser trochanter. Here you see a flattish lesser trochanter image, and the proximal fragment is thereby internally rotated. Whereas if you see, the patella has shifted medially, so both are internally rotated. So this kind of neutralizes, and this again, if you fix it in this may come out to be okay. And here you have this external rotated, very prominent lesser trochanter, and the patella shifted laterally. So there is more than one way to skin a cat. You have the profiles with you, both of the lesser trochanter and the patella, to check your alignment. Now, even though nails are preferred options, they are not without problems. And in one study, it was found that the problem of varus creeps up even in the option of nails. And all the complications are secondary to the varus. So it is not as if the nails are immune to varus positions. You have to guard against varus reduction and fixation, as also take care about the length and the alignment issues. So again, in the choice, as I have said, both perform well and they have their own strengths and weaknesses. And if you have to choose, avoid the nailing in valgus and use the plate biologically. That really is the crux of this. Let's just take it a little further. In a relatively simple fracture, both the plate or the nails will work, but if there is a trochanteric extension, you may think of a biological option of a plate. A more so-called complex fracture in which there is a lot of combination, then I think nailing is to be preferred. If at all we use a plate, we need to bypass any comminuted area so that we get a very good hold on the proximal and the distal fragment without putting screws too close to the fracture, because then that becomes a very rigid fixation and subsequent failure, because there is very little callus, if any, and it is then doomed to delayed oblique non-union. So again, somewhat repetitive, but long intramedullary nails are very good, very safe option. Take care to avoid any malreduction in varus, and plating, if chosen, has to be in less invasive techniques to preserve the biology. Just another example to emphasize what I have just said, that a blade plate, DHS or similar instruments, implants, if put in varus, they will invariably fail. This is a patient who I inherited some time ago. A long nail, I mean, the reduction, and did it go into failure? I think definitely one screw in a long nail is not adequate. This is a comminuted fracture here, and a single screw cannot hold the rotationary forces very well. So it failed, and then this patient underwent another surgery with the proximal femoral locking plate. The length is good. The screws are away from the fracture site. The length of the screws into the neck and head are good, but as you see, the reduction is in varus. So inevitable would happen. And just a close-up of the mode of failure, the implant cutting through, or in fact the head and neck portion going into more and more varus, because this is a rigid implant. So it is the fragment that goes down and the nail stays there, cutting through the rest of the fragment. So this patient had to undergo a long stem prosthesis. Choice of implant is critical, as is the technique. And what I would sum up the thing is that a fracture needs to be evaluated. You need to be careful what kind of implant you're going to plan. there must be no varus, whether it is a plate or a nail. You have to have adequate length and the strength of that. Needless to say, majority of the times you will be using a intramedullary nail, but there's no doubt the plates can be used, and they are preferably used as a biological option. Thank you.
Thanks, Dr. Sadhoo. Very concise and to the point as usual. I think there's a lot of useful information there, and I think it should clear the understanding of a lot of people in terms of how you deal with these subtrochanteric fractures. So I think if there are any questions, we'll take them now.
So while we are waiting for a question, so how often we need to do open reduction in these fractures? Because
yes, good question. What my philosophy in this is, I try close reduction, but I give myself a time range by the clock. I mean, I give a certain time. I don't keep at it for hours together. I give it a certain time, depending on the kind of difficulty of the fracture or the so-called personality of the fracture. I give it a certain time, 10 minutes, 15 minutes, you choose. And then you give it a good try. But if not, you open it, you hold it, you pass the guide wire, you pass the nail, before reaming, close the wound. So I would not have a very great threshold of, come hell or high water. I would not hesitate to open the fracture if I'm getting into trouble or causing more damage by insisting on being the so-called indirect reduction technique only.
So I think in these fractures, again, reduction is critical. Don't expect the nail to reduce the fracture for you. You have to pay attention to everything, including the entry point, and also get an adequate reduction before you start your nailing. So if you don't have a good reduction, you shouldn't be nailing that.
The nail will follow your path of reamer. So
Yeah.
it is a procurvatum or that kind of deformity, then your nail would hit the anterior cortex because of its natural anterolateral curve. So you could cause more damage. Sorry, Dr. Janki, you were saying something.
Please excuse me because I have been called in the OT. So please carry on the discussions. Thank you very much. And it was a real pleasure listening to you again.
Thank you.
We'll meet up soon.
Thank you.
Okay, so bye.
thank you.
Bye-bye.
Yeah, sure.
So one more thing, sir. Because even if we are doing open reduction, do you go with the lag screw, circlage wire, or plate, means provisional fixation, and then do the nailing, or just to hold with some instrument and then again proceed it?
Yeah. If my plate holding, bone holding clamp doesn't hold the fracture stably, or the circlage wire proves inadequate, there's a very good trick. You can use a very small plate, let's say 4-hole plate, unicortically on the lateral side with 2 screws on each side, and then this will prove very useful. I mean, 4-hole plate doesn't take much of an exposure. Once you reduce and hold it with 2 up and 2 down unicortical screws, your job is done. Close the wound, ream, so that reaming products don't come out, and at the end of it, you can leave the plate or take it out. I would much prefer you take the plate out, because if you leave it there, it may convert a preferred relative stability into an absolute stability, and thereby cause delayed or non-healing and breakage of the implant.
And what about the rotation, sir? Because when we see on the Shyam, like if we are doing in the lateral position, the nailing, so how to check for the rotation? Because even because in that position, sir, it's more chance of getting into internal rotation.
Indeed.
So
very good point. This is the reason that in supine you have a much better idea of the rotation, but in lateral position you are at a loss to find out. I think it's the overall alignment of the fragment. If you can see the proximal fragment going into flexion and abduction and external rotation, whereas in lateral position the limb tends to fall into varus and foot goes into internal rotation. So while you are reaming or you are reducing, you need some kind of hold on that fragment. If you are lucky enough and it's a solitary jagged line like a reverse oblique, then the fracture surfaces will tell you, okay, and now we are aligned together. Then you don't need to look at anything. But this no longer applies if you have a combination at the fracture site, or there's a segment which is, say, a lot of butterflies. But I think it will before you put the distal screws, the problem comes not with the proximal screws. But once the proximal screws have been put, then look at the foot, the rotation of the foot underneath the drapes, and you have to have in your mind's eye, you have to have it in adequate external rotation, or the patella should be in line. Essentially, just turn the picture 90 degrees in your mind, so that the foot, if it is not there's no pigeon toe deformity, as it were, the foot is not internally rotated, that should raise your hackles before you put the distal screws. Any distal screw, whether it is in plate or in the nail, you have to have adequate external rotation to match the external rotation which is natural. Yes, there is no radiological landmark, or it will be very difficult to compare in lateral position, because the picture generally is not as clear as you are struggling a little in this. Yes, I think the thing to avoid is varus and internal rotation.
Is it always necessary to put a long nail, or we can do it with the short nail also?
If it is a relatively young person with strong bones and proximal proximal fracture has no extension at all, then a relatively short nail would be fine. But anybody who is having so-called osteoporosis combination, where you feel that an area of relative weakness would be, stress riser would be evident at the end of the nail, then I would rather put a longer nail. Anybody over 50, I think, is suspect. I would put a longer nail there.
And so when in young you put the short nail, so how much short it should be?
Well, there is no formula for this, but I think 150 centimeter, if I just have to throw a figure at you, but at least that much. And you know, those the nails which have a locking screw mechanism, they go from lateral to medial or somewhat obliquely. One screw should be adequate, because that will give you relative stability, provided the reduction is not in varus and there is no combination, or very little combination.
So as you mentioned that when you put a provisional fixation with a plate, at last you should remove it so that there is no absolute stability but relative stability. So even if we are putting the surplus wire, usually two, sir. So after the fixation, sir, we should remove the surplus wire also, or we can leave it?
No, cerclage wire and plate are two different beasts altogether. They have nothing to do with each other. Cerclage wire just can have a very weak hold. It is there as an internal suture, no more. Whereas even in a unicortical bone with a unicortical plate with the locking option, it will give you absolute stability. Which even if there is a small gap, it will not heal, and also the the callus formation will be at least delayed, if not completely gone. So no, plate must come out, but only after you have done the reaming, because we don't want to lose the very precious reaming products. They must stay as a natural bone graft.
So in subtrochanteric, sir, there are so many cases of failed fixation also comes. So is there any difference while fixing those fractures with failure or the from the primary, sir?
If I understand your question, you are saying if the subtrochanteric fracture has failed.
Yeah.
Okay.
Then yes.
Invariably, it will fail in varus. That is one. So all you need to do is counter the varus. Now, my favorite would be one of those blade plates. I'm a great fan of blade plates because I can produce adequate valgus with blade plates. But a nail would be a very good idea. What you need to avoid is you should not be too lateral in your entry with the nail. Because if you go through the piriformis fossa like puncture nail, then it is much more aligned than if you were to put a lateral, too far lateral an entry of the proximal nail, which pushes the fragment into varus. If that makes sense, is that clear?
Yes, sir, it's clear. So one more thing, sir, what we face problem while making the entry hole, especially in the subtrochanteric fracture. So how to do that, make it easier, sir, because of the displacement, or even if we are doing the close reduction, the entry point is not as accurate as in other fracture like intertrochanteric and all.
Yes. Generally, the recon nails have a trochanteric entry point, not the piriformis entry point. And if you see radiologically, there's a tip of the trochanter visible. It's like a peak. So you should stay at the peak, because invariably you will veer somewhat laterally, or the bulk of the nail will come out a little laterally. Do you understand? There is a peak of the trochanter which dips into the piriformis fossa. So stay at the peak. Take a sharp guide pin or a thick K wire, make a hole, and then ensure that you hammer it in, it stays in, and your guide wire exactly should follow that. You have to confirm and reconfirm it, not only in AP but in lateral position also. You should not be too anterior with your entry point, because the nails have, or the femur has a anterolateral curve. If you put a nail from too anterior portion, it will the distal portion while going of the nail might actually hit the anterolateral cortex.
So one more question, sir. Like as you have mentioned about the blade plate also, few of our postgraduates because it is not performed commonly nowadays, sir. So can you describe the technique of putting the blade plates, sir?
You can. It's a pity. To my knowledge, I think AO have more or less discontinued the blade plate. So fortunately, our local manufacturers are still good at it. They can make it for you, and you have to have at least a 135-degree blade plate, 140. They will make it for you. If you have difficulty with that, sometimes because the fracture is mobile, if you are going in for a re-surgery, it is because there is a non-union.
Yes, sir.
So you can, if necessary, nibble a little bit of bone so that you get a valgus position. Valgus position, or a little slightly exaggerated valgus, I would call, not normal, slightly exaggerated valgus is the key to union. You must not accept any varus at all. This is why pelvis X-ray is such an education, because you have a normal hip which tells you what is the native neck shaft angle. So try and aim at least a minimum that much, if not 5 or 7 degrees more than that. And the blade plates have an option that you can, the beauty of the blade is, unlike DHS or DCS, they do not take any bone away. You do not have to neem at all. You don't have to drill or anything at all. It just goes. It preserves whatever precious bone is left. And because of those slightly raised side fins, you automatically get rotational stability. So blade plate is a magic implant. I know it is difficult, but once you get the hang of it, it will save your life at many times. I'm a great fan of blade plate.
But it gives only one, I think, attempt, because if the entry is wrong, then it will be very.
I think what you should do is the chisel that is provided, that you have to ensure that while you are entering both in the AP and in the lateral view, in the lateral view, it must stay in the center. Must. If you are veering away, then take it out and start again. Let me start again with AP view. You have to aim for either for the center or preferably for the infero-medial part of the neck and the head. Now, even if you have a previous DHS, the infero-medial part would still be virgin. So you would still not lose the hold. So aim for, your guide wire that goes before you start the chisel, that gives you a damn good idea where the chisel might go, because that literally is to show where the chisel should go. And chisel, once you have advanced from the near fragment, that is the cortex close to you, into the distal fragment, make sure it stays in the center of the fragment, in the lateral view and in the AP, in the center, but preferably slightly below, infero-medial to the center. That's where you get the maximum hold, and then you have a mile of bone before the implant will ever cut through, provided you have not reduced it in varus, when the blade will break in varus.
So as you mentioned, sir, we should remove bone to make it slightly valgus. So it's like work as a valgus osteotomy.
Yes, indeed. Just like in pertrochanteric fractures which have malunited or non-united, and you put this, or even in a fracture neck of femur, you produce certain valgus.
Yes.
The neck femurs fail because the reduction is in varus, or they go into varus. That's why they fail. I have shown many times in my lectures that all you need to convert this is the shear forces into compressive forces. The nature will take care of the healing. You are nobody to heal. You cannot heal anything. You are just to help the natures to not to obstruct it and put it in a good alignment for the nature to work.
Sir, I think it's great, sir, and it's lots of information as you have in your lecture and during the discussion. So I hope it will be very useful for all of us, all the postgraduates. So thank you very much, sir.
Thank you very much. I certainly hope so. And thank you for having me. Bye-bye, Dr. Janki, and my thanks to Dr. Mukhopadhaya again. Bye-bye.
Thank you. Thank you very much, sir. Great, sir.
Good evening. हाँ जी, सब ठीक है?
हाँ सर, yes.
Take care.
Yes, sir.
Bye-bye.
Thank you, sir.